Top Med Talk.
Nick Harrison here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
My name's Arthur Fleboris, and I've got the privilege of chairing this session with some very great speakers that will be following. Our first speaker is Professor David Storey. David's probably well known to most of you, but for some of you who may have had the rip-winkle infect and been asleep for the past 100 years and don't know David, he's the Foundation Chair of Anaesthesia at the University of Melbourne and Director of Anaesthesia and Perioperative Medicine at the Melbourne Medical School. He has a very strong and long track record in research and academia, and he continues to be active in those areas. He's in the executive of the ANSCA Clinical Trials Network, and aside from doing creating the evidence, he's very, very strong in terms of translating that evidence into practice. So I'd like to welcome David to the podium.
Thanks, Arthur, and good morning. I'm going to talk about 3 randomised trials, and I think, as we've been aware, there's been some fairly spirited discussions about the applicability of randomised trials to individual patients. And I also think one of the important things is to look carefully at randomised trials and the subtle messages that are often hidden away in them. One example being the POISE-1 study, which was of beta blockers, which showed that whilst there was fewer infarcts, there was more strokes with beta blockers. But the main take-home lesson to me was that patients on beta blockers need greater post-operative surveillance for bradycardia and hypotension. So I think they're often more, and that was the more subtle but probably one of the most important messages out of POISE-1. So I want to talk about 3 relatively different randomised trials. But first I'd like to acknowledge the traditional owners. And I have no particular financial but considerable academic conflict of interest. So many of you will have seen this document from colleagues in the UK from the Royal College of Anaesthetists. And what I want to emphasise is what they're talking about there. So before surgery, during surgery, early after surgery and late after surgery. And so for those non-anaesthetists in the room, they would associate us as anaesthetists with that second blue box, the during surgery. But increasingly, as you can tell, we're getting involved in preoperative assessment, preoperative optimisation, early after surgery. I want to emphasise the late after surgery because I think this is one of the ones where we will be advancing considerably. And 2 examples would be the patients who have asymptomatic troponin rises or MINS, myocardial injury after surgery, and whether they require ongoing management as if they've had a cardiac event, which they have. So do they need secondary prevention, which is provided best by our physician colleagues. Another example is acute kidney injury, which I'll talk about a bit today, and how those patients should be managed longer term. Should they be treated as patients with newly diagnosed chronic kidney disease? And I think there's some of the debates for now and for the future. So the first randomised study I want to talk about was published in the BMJ this year. I'm one of the authors of this study, so I do have a degree of positive conflict of interest about it. But the person who drove it is the person here, Ianthe Bowden, who's a physiotherapist at Launceston. For anyone not from Australia, Launceston is in northern Tasmania and is a relatively small place. So to generate a paper in the BMJ from Launceston I think is a major achievement. Ianthe is a PhD student with my colleague Linda Denny, who's the Professor of Physiotherapy at the University of Melbourne. And what Ianthe was interested in looking at was preoperative education of patients by physiotherapists trying to reduce the incidence of patients developing respiratory complications after abdominal surgery, which is one of the major risk factors for respiratory complications. Now, just to make you feel inadequate, this is Ianthe playing both rugby and hockey for Australia. And she also has 3 kids. So she really is one of these superwomen. So if we look at the Pico, or the population intervention control outcome and timing of this study, so compared to usual care, and in usual care in this setting was an information booklet preoperative education and breathing exercise training within 6 weeks of surgery by physiotherapists reduces the incidence of postoperative pulmonary complications after abdominal surgery. So that's the hypothesis. There are 11 physiotherapists across three hospitals with over about 440 patients randomised into two groups. So preoperatively, the intervention was patients received an information booklet as a control or an additional 30 minutes of physiotherapy education and breathing exercise training. I think one of the important components of this was it included explaining to the patients why they may get into trouble, that using in appropriate lay language the idea of atelectasis early after surgery and the importance of trying to overcome that through deep breathing and the importance of engaging in these exercises as early as recovery, remembering that physiotherapy often starts on the first day after surgery. So this is day 0. So this is the Melbourne groups. There's a number of different ways of diagnosing postoperative pulmonary complications. For our physician colleagues, they'll be very pleased to see that at the bottom, so you need 4 or more of these, but a physician diagnosis of pneumonia is one of those 4. And other things associated with new symptoms and signs we commonly associate, particularly with pneumonia, but also other respiratory complications, including hypoxemia. So if we look at the two groups, so roughly 220 patients in each group randomised, and so the median age is in the early to mid 60s, slight predominance of men. They're on average overweight, and there were only a very small number of very obese patients. So I think when you're considering the results, it's important to remember the ASA status. So these were a relatively healthy group of patients. There were about well over a half are ASA 1 or 2 or healthier patients. Now, these are the findings. So what they anticipated was that there would be a 10% absolute risk reduction from a 20% baseline. What there actually was more like about a 23% baseline or control rate of infection and a 15% absolute risk reduction. So this is a very large reduction in postoperative pulmonary complications associated with this physiotherapy exercise. And I came into this trial after it had started to try and help. Anthony asked me whether I'd be interested in being involved, and I provided advice. But one of the things I sat down with Anthony actually at a college meeting in Auckland and went through all the elements of a randomised trial. There's now the Spirit guideline for writing protocols. I went through all the elements. Anthony had done everything. That's why this paper got into the BMJ. She'd looked at blinding, she'd looked at randomisation, she'd looked at the control group, she'd sorted all this stuff out. The main suggestion I made to her was that she also look at mortality. So this is not the two groups. So the bottom line is the patients who did not have a postoperative pulmonary complication, and this is mortality after 12 months. So if you look at that, about 5% of the patients who did not have a complication, but still 1 in 20 died within 12 months. But more like about 15% died if they did have a pulmonary complication. So the importance of this is that it emphasises again that a complication in the intra or early postoperative period is associated with long-term adverse outcomes. It isn't just something bad that happens for a few weeks. This has long-term adverse outcomes. If you look at the Kaplan-Meier curves comparing the intervention and the control group in this study, there's a relatively small difference, about 2%, and you need a much larger sample size to determine whether the intervention in fact alters mortality. But it definitely reduces infections. So again, this emphasis on the importance of long-term effects of complications. So what we knew was, this was not new news, that pulmonary complications, but we're able to quantify the effect longer term in a prospective database. But what this showed was that in a randomised trial, a relatively straightforward intervention from our physiotherapy colleagues. And I think when we talk about multidisciplinary care, we need to remember the nursing staff, we need to remember allied health, we need to think broad. And so that's what this study is telling us, a relatively straightforward and I would assume cost-effective intervention. But we've talked a lot about health economics in this meeting, And this study really evolved before we were really thinking actively about health economics. It's something we'd want to consider. And we may be able to retrofit it, but retrofitting health economics is quite difficult. So, what's this all about? In 2016, the Australian Society of Anaesthetists meeting, I was invited to take part in a tongue-in-cheek debate about ERAS and whether we keep patients dry or fill them up. And this was like, nirvana for me. I was able to say something grossly inappropriate, inflammatory and everything else. So what I suggested was that people who follow ERAS, it's a death cult. They dry them out and they kill people. But what I was able to point to was this study, the RELIEF study. So the RELIEF study is a 3,000-patient randomised trial run by the ANZCA Clinical Trials Network. Paul Miles, who many of you will know, but some particularly physician colleagues won't know, was the leader of this study. He is the chair of anaesthesia at Monash University and probably the world's leading, I would regard the world's leading clinical trialist in anaesthesia. And so this study was underway when I gave my inflammatory talk. I'd also like to point out that the RELIEF study, when it went through NHMRC in 2012, was the highest ranked grant of all the project grants of NHMRC that year. So if you consider 15 years earlier, when the master study went through NHMRC, one of the reviews just said, I didn't know anaesthetists did research. And so in a 15-year period, we went from 0 to 100, literally. So the RELIEF study was published this year in the New England Journal, and I'm one of the co-authors of this study. So the hypothesis was, and this is really important, that a restrictive fluid regime in adults undergoing major abdominal surgery leads to a lower rate of complications and a higher rate of disability-free survival than a liberal fluid regime. That is, that dry is better. I'd like to point out that disability-free survival, so this is a combination of being alive at 1 year, but also not being disabled. And the metric we used was the WHO Disability Assessment Schedule, or HUDAS, which is a very validated disability scale. But remember, unlike a lot of the metrics with disability-free survival, the higher the number, the better you are. The flip side is being dead or disabled, sorry. So population adults, higher risk complications, major abdominal surgery that included a skin incision, so excluded purely laparoscopic surgery, expected operative duration of at least 2 hours, expected hospital stay of at least 3 days. Now, if you look at it roughly, and there were time and weight caveats that I won't go into, but the liberal regime was a 10 ml per kilo bolus and then 8 ml per kilo per hour. But importantly, this went out to 24 hours. So this includes early post-operative care of the patients. So 1.5 ml per kilo per hour after that. The restrictive aimed for 0 fluid balance and was 5 ml per kilo, then 5 ml per kilo per hour, then 8.8 ml per kilo over 24 hours. So this is the outcome. So the patients are in many ways similar to the Anthony's group. They're in their mid-60s. The sex balance is relatively similar. The body weight is about the same. This is a sicker group of patients than in the Anthony study. If you look at ASA3, over half the patients are ASA3, so it's a relatively sick group undergoing large operations. Median duration of surgery was actually 3.3 hours. And about a quarter of the patients were planned to go to intensive care after, so planned ICU admissions. Now, if we go through this, I think the most important one is to consider, so we've got duration of surgery, then median infusion rate. So the median infusion rate in the restrictive fluid group was 6.5 ml per kilo per hour across the entire operation. In the liberal fluid group, it was almost 11 ml per kilo per hour. So there's quite a marked difference in the fluid administered to these patients. And if we go down to the bottom, which is at 24 hours, so the median fluids in the restrictive group were about 3.5 litres and a bit over 6 litres, so 2.5 litre difference between the two groups. So that's a large amount of fluid. And the weight gain in the restrictive group was about 0, and the median weight gain was about 1.5 kilograms in the liberal fluid group. So the importance of this being that the separation is about 2.5 litres. That was the anticipated fluid separation from our pilot work, but also slightly more in both groups, about 500 mils more in both groups. So in terms of results, there was no difference at all in disability-free survival between the groups. Remembering that we anticipated the restrictive group would be 20% better, they weren't. But not more importantly, but if we look at other complications, so for the ERAS true believers, surgical site infection was greater in the restrictive group. And this is probably one of the biggest arguments has been, you give them too much fluids, you'll screw up my anastomosis, you'll flood everything. That is not supported by this. I'm very aware that there are people who will say, well, look, that's not my restrictive practice or that's not my liberal practice or whatever. But in this study, with these sort of volumes of fluid, this is the difference. But probably the biggest and most significant difference is this increase in acute kidney injury. So if we remember that acute kidney injury using the KDIGO criteria is a 50% increase in creatinine. And so, but also even a stage 1, even that early, and then it escalates, but stage 1 is still associated with increased mortality long term. It is a significant injury to a patient afterwards to develop acute kidney injury, even grade 1. So we have a 3.5% absolute increase, relative risk ratio of 1.7. Similarly, there was relatively small numbers of renal replacement therapy, but it was greater in the restrictive group. The only vague difference that was in favour of restrictive was there was a lower incidence of pulmonary edema, which is unsurprising. And it was about a 1% difference between about 2 to 3%. But because of the numbers not clinical, you could argue that might be clinically significant. So what have we found? We've found that the restrictive approach using the protocol that we used, and I emphasise the protocol that was used here, and that may differ from people's individual practice, did not favour restrictive approach and in fact favoured the more liberal approach. I would like to emphasise when we look at this work that this is very different from goal-directed therapy. And so it's a different question. Goal-directed therapy, we're using devices to measure cardiac output and to manage cardiac output through both inotropes and fluids and vasopressors is a different approach to this. Having said that, the restrictive group had a more vasopressor approach to hypotension. I would like to point out just in passing, if we consider CPET, CPET started at Western Hospital with Paul Alder 25 years ago. When I was Paul Alder's registrar that many years ago, he was also doing goal-directed therapy, more intensive being with pulmonary artery catheters. But I would like to point out that Paul was doing CPET and goal-directed therapy a quarter of a century ago. And I think we need to acknowledge his vision in that area. Look, the evidence was soft, yes, and probably is soft to a certain degree now. But here's this guy in a small hospital in Melbourne getting shellacking from the Royal Melbourne and the Alfred because he's a bit of a weirdo out in the West. Well, that's how they saw him. And he was probably heading in the right direction in a lot of ways. So the relief conclusion. So among patients with increased risk for complications during major abdominal surgery, restrictive fluid regime was not associated with a higher rate of disability-free survival and was associated with increased acute kidney injury. Now, I want to talk about afterwards, and this is a study I'm not involved with directly, but published this year in The Lancet is another randomised trial. This is from the Netherlands. It's a single-centre trial. And so their Pico is in patients undergoing intermediate surgery, and I'll describe that more in a moment. A personalised e-healthcare program will lead to faster return to normal activities after surgery than usual care with the placebo website. And I'll explain what all that means. So what they did was they're looking at patients who are having operations such as laparoscopic, relatively minor gynecological surgery, laparoscopic hernia repair and laparoscopic cholecystectomy, pretty middle-of-the-road operations. They used a language-specific patient-reported outcomes measure to work out for the individual patients what normal function was for them, what their normal degree of activity was. And there's actually a very good accompanying paper for this. Unfortunately, a lot of their e-health interventions are in Dutch, so you can sort of get the vibe but not really know the details of what they're doing, but the paper's in English. So what they had was a combination of an app and a website and an activity monitor to provide patients with understanding their expectations. So this is going back to Yanthe's work, the idea of patients understanding what's going on. In my view, a lot of ERAS is about patients and everyone understanding what's expected, what's going on. But an ability to sort of follow up how they're going, but also the plan was that they would not have a post-operative face-to-face meeting, but their follow-up would be run through an online communication. So the patients were communicating with the people looking after them online, and they could make queries, they could make questions, and they got feedback as well. So app, computer or PC, and an activity monitor. The control group had basically a placebo website, and this is to help blind it. So the patients knew they were going into an intervention that had online components. They weren't told about the complexity. And so the placebo group, Yanthe demonstrated quite well that actually there was quite good blinding amongst the patients, that they did not anticipate which group they were in. So it is one of the issues with consenting for these sort of studies is you need to limit what the patients know about what's going to happen to them. But it helps blind these randomised studies, which is particularly important. So what happens? So this is about slightly more women than men. Younger patients, so this group's about a decade younger. And importantly for e-health type interventions, they're all Dutch, so they spoke the language. And they're all pretty, at least half of them had higher levels of education and most were employed. So this is a particular, you could say it's a very middle class group of people, and I think that's important to consider. I've been doing a lot of work around working with patients who are culturally, linguistically diverse. We've worked with older Italians associated with St Vincent's in Carlton and with Vietnamese patients out in a Western hospital. And the cultural component of this sort of thing is incredibly important. So the older Italians, I was very surprised because if we look at multidisciplinary, so the people in the team are the professor of Italian, some IT experts, and someone who's an academic in communication. And the professor of Italian said a lot of the older Italians in Melbourne can't read in any language. And I didn't know that. And in fact, when we did focus groups in some of the Italian social clubs, we found that the average education was 4 years of primary school in Italy, in the early post-war period. So we're trying to ask patients, of that sort of grouping in English to take part in our trials, which is why it just isn't working. And so we're interested in trying to work around that. We have a program of research about that. So I think when we consider any e-health intervention, we need to consider both language but also culture. The Vietnamese patients in the West, a lot of them have come from, escaped Vietnam after the Vietnam War. And they are very concerned about government. And so their major concern is that any data they're entering, they don't want it to go to the government. One of my PhD students is a Vietnamese pharmacist. I could have told you that. But she tells the story of her wanting, for high school, because she came out on a refugee boat through Malaysia, went to primary school, high school in Australia, and she's doing the family tree for a high school project. And she went to her grandmother and said, "Can you tell me the family tree?" And her grandmother said, "Are you a communist or something? Why do you want to know this?" And it just emphasised to me the cultural importance of how we deal with information, the questions we ask, and the complexity in the countries that we live in, let alone working with Indigenous people in each of our countries. So this is what they found. So that, as I said, intermediate level surgery. What I thought was really interesting is when they asked the patients preoperatively, when did they think they'd be back to 100%? The patients said about 2 weeks. In the intervention group, it was about 3 weeks, and in the control group, it was about 5 days longer. But you can see that there's a clear separation of the curves. So what this showed was that this e-health approach allowed them to return to full activities of daily living about 5 days earlier. So these are relatively young people, still in the workforce predominantly. So they did look at the economics. So it cost them about €200 per patient extra. And up in the right-hand corner is what's called a cost-effectiveness plane. And when I first saw one of these, when I did a short course in health economics, and I really, really recommend those. You can do one-day short courses face-to-face. They're taught at Melbourne, they're taught at the other number of the universities. It's a really helpful way to get your head around, basic health economics. It doesn't mean do it yourself, but at least you can understand where people are coming from. So the way a health economics plane works is you start in the middle and you do something. And the x-axis is clinical outcome and the y-axis is cost. So where you really want to be is in the lower right-hand corner. And one of the reasons metformin is the most, primary drug in type 2 diabetes is because the studies showed that it saved lives and saved money. And so, but unfortunately, one of the things we do is we often, one of the difficulties in a lot of what we do is it'll be slightly more or a lot more expensive with some clinical benefit. And so we need to study this to make it easier to understand and argue with our administrative overlords. So a personalised e-health intervention after abdominal surgery sped up return to normal activities. And I think particularly in our setting, the implications of this for rural health are considerable. I think for patients who need to leave a hospital, particularly those who return home who've had major surgery, these are sort of interventions we should be exploring in collaboration with their general practitioners. So what are the take-home messages? And we need to remember that from the science philosophy version is we are more confident of causation after a randomised trial than just association. So I'm going to give what I call the Tony version, the quick and simple version of the three take-home messages. The first is that physiotherapy education for post-op is good. Don't dry out your patients. E-health can help afterwards. And just to prove I give anaesthetics, this is me in theatre. Thank you.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of APPMU, evidence-based perioperative medicine. We'd love you to find out more about them as well. APPMU.org is their website. That's EBPOM.org. And if you go to APPMU.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's APPMU.org/meetings.